Thank you. It's a pleasure to be here. So we'll start with our conflicts of interest disclosures. So Constantia and I are co-founders of Connectology. Connectology is a web service that provides patients and providers information on hospital readmission rates and other outcomes for their procedure. The data we are going to report today are based on algorithms that are used at Connectology. Funding for the development of Connectology and for the research we are going to report has been provided by the SBIR program at NIH. But none of the data reported here or the views represent views of NIH. They are our own views. I'm a professor at Stanford. The work that I will report today is work that I primarily did when I was on a leave of absence and when I consult for Connectology. So, beginning 2013, Medicare has changed the way it pays hospitals. So now hospital reimbursement is not only based on DRG codes, it includes this readmissions penalty. So if a hospital's readmission rates for certain procedures, primarily for congestive heart failure, heart disease, and pneumonia, are higher than average, then the hospitals get penalized. And the penalties can be anywhere as low as 1% of Medicare's reimbursement, but over the next 3 years, it's going to increase and it can get as high as 3%. The formula that Medicare uses is admittedly very complex, but the whole system is based on a premise that seems conceptually very simple, that there are things that you can do to keep patients from coming back to the hospital after they are getting discharged. Some people believe that that premise is valid, but some other people believe that that premise is fundamentally flawed. So what we want to do today is discuss some data that we have regarding hospital readmissions, what they mean for you, and then have a broader discussion about this readmissions challenge and what are different ways of addressing that. We want this to be conversational, so please feel free to interrupt us. And as we mentioned earlier, we are going to split the presentation. Constantia is going to take the first half, and then I will take the second half.
And that's for the recording.
Oh, okay.
So we need it.
Yeah. We can hear you.
Okay. So, up here we have a quick roadmap of the pieces that we're going to cover today. And I'll start with the overview of the problem that we are all pretty familiar with, and then get into what it means for Stanford, what's the Stanford picture, what does it look like in terms of readmissions, and then close with some areas of what can be done about this issue. So Stefanos already alluded to all of this. Just briefly want to give a more visual map of the issue. Medicare has indeed started penalizing hospitals for readmissions. The reason is that 1 in 5 elderly patients end up back in the hospital within 30 days of their discharge. It's a pretty big problem. It's costing Medicare $26 billion every year, and Medicare believes that $17 billion of that is avoidable. And they believe it's avoidable because there's huge variability in readmission rates across hospitals. And this is what they are trying to minimize with the penalties. Now, on the other side, we have hospitals, especially academic centers such as Stanford, and they are reacting pretty strongly to these penalties based on their mission. The mission of academic centers is to provide the highest end quaternary care, which in turn attracts the sickest patients. Oftentimes, those patients are also poor, and therefore, academic centers feel that they're being unfairly penalized for things that they cannot control, such as socioeconomic factors. So there has been a lot of outcry in the lay publications in the New York Times, with hospitals reacting strongly to this. And to drill into this a bit deeper, Stefanos already mentioned that the penalties are pretty high, 1 to 3% reduction in payments from Medicare to hospitals. Given the very thin margins that hospitals operate under, this is a huge deal. And one Harvard physician has called this crazy. So the specialties that are initially being targeted are heart attack, heart failure, and pneumonia. They are the specialties where we have the largest variability in readmissions. And one academic center that is very badly penalized when it comes to heart failure is Barnes Jewish Hospital, actually. And one of their physicians was recently in the New York Times saying that physicians from all over refer their heart patients to my facility, but those patients can skew readmission numbers. The weaker your heart, the more advanced your emphysema, the more likely you are to be readmitted to the hospital. He's just expressing the frustration that his hospital is obviously being penalized unfairly because of the sickest patients that they are attracting. The consequence of these readmission penalties are huge for hospitals. Over the next 10 years, an estimated reduction in revenue for hospitals is $158 billion. That's $16 billion a year. And people are concerned that such a reduction in revenue will put huge pressure on hospitals to cut down on programs that are currently ongoing, targeted at patient safety and increasing patient survival, reducing mortality. And what's the point of reducing readmissions if you're going to increase mortality? One physician said, very characteristically, dead patients can't be readmitted. So it's a catch-22, really. Now, should Stanford be concerned?
1 to 3% reduction, is that on just those 3 DRGs, or is that based on those 3?
This is for those 3, but Medicare has plans to expand the penalties and have them hospital-wide, but this is for these 3. Yeah. So in terms of where Stanford stands and whether it should be concerned, the arguments that Stanford is an academic center and Stanford attracts the sickest patients is not likely to fly with Medicare. The arguments that Medicare presents and the picture that they have in mind is the following: that there is variability even within academic centers. So you can argue that you're an academic center and therefore different from everybody else because the variability exists within your own cohort. So Cleveland Clinic is among the highest, with readmission rates go up to 21.6%, whereas Creighton, Emory, and Dartmouth are among the lowest in readmission rates, 9.4%. And this picture hasn't changed since 2004, according to Medicare's analysis. So the fact that you are an academic center is not going to fly with Medicare. Now, the fact that you're treating sicker patients is also unlikely to fly because their analysis shows that some safety net hospitals that also attract poor and sick patients don't get penalized because they have low readmission rates. And if we look at the safety net hospitals in our area, Santa Clara Valley Medical Center is the one that has the lowest readmission rates and is not getting penalized by Medicare. But 3 other ones, Alameda County, San Francisco General, and San Mateo Medical Center, are all getting penalized by Medicare. Now, if you look at those penalties and put them side by side with the median household income in the counties where these hospitals operate, you will see there is a huge correlation between readmission penalties and median household income, with Santa Clara Valley being in a more affluent area than the other hospitals that are getting penalized for their readmissions. So the Medicare formula does not risk adjust for socioeconomics. That's the bottom line. That's their current formula. Trying to argue otherwise is going to be tough. This is the formula they're using. Yeah.
So I'm trying to relate those as correlation or some cause and effect. Am I assuming that the poor cohort in Santa Clara Valley is not as poor and disadvantaged as the poor cohort in San Francisco County?
Yes.
Okay.
Exactly.
Whoa. But that's the median household income of the area. It's not the median household income of
Yes,
the patients going there. Is
But
that
the
data
poor are
available?
poorer.
We don't know that.
It's
Well,
a
unless we
big
do.
picture. It's an average. Like it's a median. It's a catch-all. You have to look at the actual poor population to see what their income is. With that caveat, we do know, though, that Medicare's formula does not adjust for socioeconomic risks. So what does the picture look like for Stanford? And we used the system that we developed. It's an online application. It's a web application that is currently being used by patients and physicians. And it's a hospital outcomes comparison system. It provides very specific information. It is treatment information that is treatment by treatment, outcome by outcome, hospital by hospital. It provides a hospital rank for any outcomes, any combination of outcomes, and it allows comparisons of hospitals compared to national standards, as well as comparisons of hospitals to their competitors. The analytical engine of the system contains patient risk stratification and also a risk adjustment algorithm that takes into account both the clinical and the socioeconomic risks, unlike the Medicare formula. We've launched this system in 2 complicated treatments, kidney transplantation and dialysis. And today, we'll share with you how we have applied the analytical engine to understand one outcome, readmissions, the one that we care about today. So,
Can I ask,
yeah.
I'm sorry,
Yeah.
you said complicated.
Yeah, of course.
So I can see why hospitals would be very interested in this and be your clients, right? Because they want to do a great deal like ambulatory ICUs to manage the readmit rate and keep it low because there's a penalty in the facility reimbursement. I don't know why patients would want to look at just reimbursements, just readmissions, as opposed to many other metrics of quality,
Exactly.
death rate, complications,
Yeah.
that may be more germane than
them.
readmission. Readmission is a big cost issue, but not necessarily.
Exactly. Readmissions are not presented to patients.
Oh, I misunderstood. Okay.
That's the beauty of the system, that it can provide any outcome of interest. And I will show you some snapshots of the interface. And patients are not looking at readmissions. But the system can accommodate any outcome. And so for patients, we provide the outcomes that are relevant to them. For hospitals, physicians, payers, insurers, we provide other outcomes. So it's flexible in that way. So on this side here, you see a very quick snapshot of how the system provides a hospital rank for kidney transplant centers based on their outcomes. And Stanford ranks in the top 20 for kidney transplantation. Now, applying the analytical engine to CHF readmissions, we find that, unlike kidney transplantation, Stanford ranks in the bottom 25% for those readmissions.
Risk adjusted?
Risk adjusted, yes. Now, drilling down into each hospital or doing comparisons, you get the top as the user interface for patients again, for kidney transplant. You see how Stanford's success rate maps among the best nationally. The 3 bands here are defined based on national cutoffs. And for CHF readmissions, running the algorithm on that outcome, Stanford maps in this fair category. Now, if we compare Stanford to its competition, UCSF, you see that UCSF is not as good in terms of its success when it comes to kidney transplantation. It's still good, but not in the best category. And then running the system on CHF readmissions, UCSF is better than Stanford. It maps in the good category. Now, what this translates to is that Stanford would end up paying a penalty, 1%, whereas UCSF would not be penalized. Drilling into the numbers, again, in the box, you see a snapshot of the interface, and coming back to your comment, patients see outcomes that are relevant to them. So in the kidney transplantation case, the outcomes that they see are patient survival, the percentage of transplants that last longer than 3 years, and recovery without complications. And here I will focus on recovery, which is the most relevant to readmissions. And recovery is really the negative of readmissions. It's just that patients prefer to see things presented in a positive way as opposed to negative. Otherwise, they get paralyzed and don't do anything. So we turn it into a positive outcome, recovery, as opposed to something negative, complications. So focusing on the recovery outcome, you can see Stanford versus UCSF. Stanford 73% recovery versus UCSF 57%, and this is what's driving their differential mapping of their success that we have seen previously. In terms of CHF recovery and readmissions, Stanford is slightly lower than UCSF, 66% versus 70% in recovery. The negative of that, 34% in terms of readmissions versus 30% for UCSF in readmissions. So it's only a 4% difference, but it can make a difference in terms of getting penalized or not. You may be sitting at that cutoff point, and it can make that can just make the difference.
Devil's advocate. Stanford has a large and successful cohort of heart failure patients who have transplant. UCSF is a very small adult cardiac surgical program. So at Stanford, you have all these people being managed here for the congestive heart failure at end stage, waiting transplant that skew the data. So, I mean, is there any way that's
risk adjusted, though?
Well, I've never had a great deal of faith that risk adjustment accurately or adequately adjusts risks. I'm curious in that case, because I happen to know these two services from some recent activities I've been involved in, and they're very different services because of the presence of the surgeons doing transplant.
Stefanos, do you want to address the risk adjustment issue?
So there is a methodology that Medicare uses. So when we calculated the CHF recovery, we tried to replicate what Medicare is using. So we can argue whether Medicare's risk adjustment works or doesn't work, but the reality is that this is what they are using, and if they are not capturing these risk factors, that ends up getting translated to a penalty for Stanford, but not for UCSF. Later on, we'll talk a little bit about how you can use internal data to develop better risk adjustment to complement what Medicare is doing, and how you can use that to avoid some of the penalties.
Now, since we're talking to ENT doctors, I wanted to throw in ENT as well. I'm sure you are curious as to what's happening with your specialty. It's quite unlikely that ENT is going to contribute to any penalties, but for completeness sake, we wanted to share the data with you. The specialties that are getting penalized are of quite high variability, more than 30% variability from worst to best. ENT's variability is just 8%. So it's quite unlikely that anything is going to happen within that 8%. On top of that, ENT doesn't contribute as much in terms of dollars to the big picture. There's only $1.4 billion spent on ENT, and the readmissions problem within ENT are not as costly. They only contribute only 2% of the readmission costs that Medicare cares about. So readmission costs are only $570 million. We're talking about $26 billion. So it's quite unlikely, but just for completeness sake. And just to show the exact numbers where Stanford stands in terms of ENT, again, this is where it stands with kidney transplant. We've seen CHF, ENTs to the right. It is just smack in the middle of the range.
With account readmissions, how do they do it? I mean, is the admitting diagnosis on the second admission have to be the primary diagnosis on the prior discharge?
No, it's coming back to the hospital for any reason.
You could come in for something and readmitted for some totally unrelated thing, but because you were discharged from ENT service. Okay.
That's my understanding.
So it's not ICD-9 specific.
Yes, it's not ICD-9 specific, correct.
Within what period of time are we talking?
So Medicare does a 30-day readmission. Here we have presented quarterly readmission.
Does this exclude planned readmissions?
Planned?
Yes. Somebody coming back.
Yeah, because they were asked to come back.
I would always readmit them to Packard.
Stage 2 was done, they were discharged, and they came back for or whatever it is that was going on. Planned readmission.
Yeah, I don't think we account for that. It's just readmissions, a catch-all readmissions.
30 days?
This here, quarterly. Medicare is 30 days. I'll turn it over to Stefanos for the rest of the presentation.
Yeah, that's come back to day 31. That's a strategy.
That's the end of the lecture.
Yes, that's not the problem.
Anything else you want me to stop?
Okay, so what we wanted to discuss next is what can you do about that? So these are the data. This is the formula that Medicare is using. They have their own risk-adjusted methodology. It's not perfect, but it's been used to penalize hospitals. Is there anything you can do about that? So we'll take a step back and we'll discuss 4 ways in which you can address this problem. The first one is code things more accurately. So Medicare is using a risk adjustment methodology. They are taking certain information and they are using that to calculate the penalties. If you understand deeply what they are doing, and then you understand deeply also your internal data, you can make sure that you represent the risk of your patients accurately so that the risk adjustment is going to work to your advantage. And that's usually the lowest hanging fruit. Now, most physicians may react to this administrative solution, and what they may want to say is, wait a second, if we can actually control readmissions, let's see what we can do about that. So there are 3 additional strategies. The next strategy is, first, identify patients who are at high risk for readmissions, because these are the ones you need to be focusing on. You don't want to focus on the ones who are at low risk for readmissions. Then analyze the data to see what works. Either learn from your internal data or learn from other providers and develop strategies that could help you reduce readmissions. And then finally, recognize that the readmissions that occur have a lot to do with the physicians who take care of the patient once they leave the hospital. So be smart in identifying which physicians to work with once the patient gets discharged. And analytics, like the ones that we are working with, can provide us with the capability to do all of this. So taking a step back, the system that we have developed, when you look under the hood, has the following components. The inputs are any claims data. So these are the data that are submitted to Medicare. But the beauty of the fact that we started with kidney transplantation, in kidney transplantation, there is a kidney transplant patient registry that has additional clinical data that are not typically part of the claims data. So when we did our risk adjustment for transplantation, we could combine both sources. We could use the standard claims data that Medicare is using plus the clinical data that providers have internally. Then we can select any treatment or condition. We can select the outcome that we want to analyze, either outcomes that patients care about, or providers care about, or payers care about, and select the time period. So over what period do we analyze the data? What is the readmissions window that we are looking into? How our predictive model works is as follows. First, we are taking all the claims data and we are creating about 1,000 different risk factors. This is a universe that is much bigger than the universe of risk factors that Medicare is considering. On top of that, we're using the clinical data to identify additional risk factors. Then we are using predictive modeling to identify among these risk factors which factors predict the outcome that you care about. The outcome of interest here is hospital readmissions. And then we cross-validate the risk factors on data from a different time period. So the problem with methods like this is if you let them loose, they start picking things that they don't necessarily make sense. And the way statisticians correct for this problem is identify the risk factors using data from one time period, rerun the model on different time period, and if the risk factors are retained from one period to the next, you know that these risk factors appear to be the most relevant ones. So let's see how the 4 strategies would play out. So the first one is code more accurately for ENT. These are some of the risk factors that came out of our ENT model. So for example, history of drug abuse is a predictor of hospital readmissions. Now, you could argue whether you can do anything about that or not. But there are a couple of things that we wanted to highlight here. Chronic pulmonary disease and anemias. These are not necessarily ICD-9 codes that appear with the claim that you submitted when the patient was admitted to the hospital. These could have appeared in previous claims. So what we do is we analyze the history of claims before the patient gets into the hospital to see what is there. If a patient has a history of anemia or chronic pulmonary disease, their risk of readmission is higher. So the other 3 columns that we have here, these are the relative readmissions risk. This is the percentage of patients that have any one of these risk factors nationally. And these are the percentage of patients that had these risk factors in our Stanford sample. So when we looked into that, we realized that there are those 2 important risk factors. The percentage in the national population are significant, but none of the patients in the Stanford sample had that. So this could mean one of 2 things. Either you don't have these patients in your sample, or you didn't code that you had these comorbidities because you didn't know that that really mattered. So what you can do is pay special attention. When you have patients with those 2 comorbidities, make sure that the ICD-9 codes show in your claim. Because if they don't, Medicare will not know that, and they're going to penalize you. These are high-risk patients. They are more likely to get readmitted, and when they get readmitted, you're going to get hit by the penalty. But if Medicare knows that these are high-risk patients, the formula changes. So that's the low-hanging fruit. Understand the risk factors that Medicare uses to calculate the penalty, and make sure that your patients who have these risk factors are probably reflected when you submit your claims.
Excuse me, so does it matter if these diagnoses appear in the medical record prior to admission and prior to surgery, or is it okay if these diagnoses appear in the record during the course of the admission? Does Medicare view those differently, as if this is an acquired from the operation as opposed to a pre-existing condition before the operation?
So as far as we could tell from studying what they do, they don't seem to differentiate. So they seem to be using them the same way. We're actually trying to get access to the algorithm that Medicare is using to get a little bit of deeper understanding of what is going on. Do they weigh them differently? But based on the information that they made publicly available, they don't differentiate. And from your perspective, what that means is you have your internal EMR data. Let's make sure, based on your clinical data, that you capture the patients that they have those 2 comorbidities. And what you can really control is the ICD-9 codes that appear in your hospital discharge claim. So make sure that those get reflected there. You cannot control the claims that were before the patient came to the hospital. You cannot control what will appear after they leave the hospital, but you can control the claim for the hospital service.
Now, last week at the medical executive committee on the Children's Hospital, we had a presentation by a company that the hospital's hiring out of Atlanta does. What their thing is integrity of billing, and they have clinical specialists who look at the bill as it's being developed, the medical record as it's being developed while the child is in the hospital, and then add onto the record into make sure all of the proper ICD-9 codes are there, so that we do get a true record of the severity and complexity of the child. And this is obviously what you're speaking to.
Yes.
Now, are you like one of these companies that comes in and does a analysis and then provides the service to the hospital to do the analytics and the retrieval of that data?
No, we are an analytics company. Our capability is to analyze the data and figure out what are the different levers that you can use. There are the claims processing and integrity of claims is not something that we do.
Yeah, we don't actually recode or help you go through each claim and correct it, but we would tell you, here are the areas where you need to pay special attention to.
Gotcha.
Something is fishy here, you need to dig deeper. We help you focus. This is what, instead of going down through the whole list, become more targeted.
Thank you.
So is this coming down to like the resident level? Because I'm the one putting together the discharge summary. So am I responsible to find out, like,
That's right.
does this patient have anemia and do I need to include it or else?
Yes.
Because, I mean, the incentives are all wrong there. I'm so busy. I mean, to be honest with you, like, this is the least of my concerns.
When,
Like,
when
Stanford
you're out in
Hospital's gonna
practice,
get
you better
bid
do it
for-
right, though. You better learn it for practice, because when you're out in
We need to have
practice, we
these
have to be.
swap
Sure, and then the incentives would be right? But for me, the resident,
But
like,
if you get in the habit of doing it, you won't think twice. You
Right.
have to relearn when you're busy starting to practice. You could be in trouble.
I completely agree, but to ask a whole hospital of residents to add this onto their thing, I don't think it's gonna be very effective.
This is
Unless I'm incentivized to do it.
Pizza.
This is a hospital problem, and it needs to be solved by the hospital. The hospital needs to, it's the hospital who's going to get penalized, and it's the hospital that needs to be sure that there's integrity to the coding process. And that's why it's going to be expensive for the hospitals to do that, but that's what they're going to do.
The goal of all this ultimately is to look at why people are readmitted and to try to fix the problem. The goal is not to hire an army or not hire an army of residents, to basically increase the acuity indices, which are going up nationally anyway as people basically mine the record to increase the acuity into, there's a problem with this, but you're going to get, if we let you, you're going to get onto other things too.
Yeah.
Yes.
Let me make two comments. One is that we undertrain our trainees in billing, coding, understanding ICD-9, CPT, and issues of both compliance and yield. And we need to bring back the Zwapko people, which we do every 4 or 5 years, to come and do a formal training program. And it's probably time to get them back on the schedule.
Smart idea.
Is it only 2 years? That far? Okay, so a couple more years. So every 4th year, we think, so that the resident.
Move on to more
No.
areas.
And that's so if I go back to why you want to be doing this analytics and going to your question, I don't think residents need to worry about every single code, but if what you identify from your data is that you need to pay attention to anemias, so I don't think you need to, something where they tell you here is a complete list of everything that you need to take care of. That's overwhelming, but what the analytics can tell you is, for Stanford, it's anemias.
So
Make sure that you capture anemias.
So SHC knows this, and at the executive board, we've been talking about those 2 indicators over the last couple of years. So they follow these informatics, they know about it, and then they try to use the EMR system to force people, instead of saying low hemoglobin, to trigger an anemia diagnosis. Yeah.
I mean, we have gotten phone calls from somebody saying, can you add anemia to your problem list?
Yeah.
Even if it's acute blood loss anemia because someone nicked
Yeah.
something.
This is where it's coming from.
That's exactly right. So
This is where it's coming from.
we are trying, but Liz's point is very well taken. The people often assigning it don't know the difference between shortness of breath and smoking and COPD, that it matters. Yeah.
And I'm wondering whether knowing why you're doing that, whether it's going to make a difference. instead of just saying this is what you need to do. Anyway, so let's move on to the next one, which goes to the question that you ask. This is the system and trying to work within the system. The other three recommendations are how can you use the power of analytics to make progress in terms of managing the hospital readmissions. So what models like the one we have developed here allow you to do is also identify the risk factors that you may be able to do something about. So again, it's the risk factors we had before, exactly the same as we had before, but another thing that was really interesting here, again for ENT, metastatic cancer, which is one of the risk factors, the national average is 8.79%, but in your data, it was 26%. So you're treating a lot of patients with metastatic cancer with ENT procedures.
Is that ENT metastatic cancer, or is that all metastatic cancer?
That's all metastatic
So
cancer.
that includes breast and all the other.
Yes. Again, then you can bring into the data.
Specific for just ENT-based metastatic cancer?
No. We can go and do it and get it quickly, but this is a catch-all for all metastatic cancer. But once you see this, which I think kind of predicts the next question, you have this high percentage of metastatic cancer patients. These are at higher risk of getting rehospitalized. So these are your high-risk patients. Shall you drill into that population? And is there something that you can do specifically about that population? So instead of focusing on every patient, focus on the high-risk patients that are relevant for you. And in your case, the data say it's patients with metastatic cancer. Now, neither of us is a clinician, so we cannot tell you what might be going on there. But what we can tell you from this analysis is this is a high-risk patient population that you're treating, and you're very different than other hospitals in that respect. The other thing that you can do is you can combine the risk factors that you identify using an approach similar to Medicare with risk factors that you can identify using your internal data. So how the model we have developed works is we can identify risk factors based on the claims data, but we can also identify risk factors based on your internal EMR data. The beauty of when you put these two things together, you can create a list of high-risk patients that are based on your internal data, but they are not high-risk patients based on Medicare data. These are the patients that can really hurt you. In the sense that Medicare considers them to be low risk, but you know they're high risk. So if you want to focus on a population of patients where you can really make a big impact, this has to be the high risk patients that you know, where you can do something about them. And if you keep them out of the hospital, you're going to get a much bigger reward from Medicare than otherwise. So by comparing your clinical analysis with the claims analysis, you can find that population of patients. Maybe there is something that you can do about them, maybe not, but what the analytics can do is identify that segment of patients, and then you can have a meaningful discussion, what can we do about that? Are there specific interventions that can help us keep these patients out of the hospital?
Do you expect, as occurs in EMTALA, that outside hospitals will learn this system very carefully, learn which patients they don't want in their hospital, and call Stanford?
That's what Medicare doesn't want to happen, and that's what you don't want to happen.
But especially with EMTALA schools, that's exactly what will happen.
Yeah. Oh, yeah.
That's a possibility. That's a real possibility. Which I think we can go to the next point because our the fourth possible strategy. So the third possible strategy, again using these analytics. So with these analytics, you can rank hospitals based on their readmissions rate. So what you can do is focus at the hospitals with the low readmissions rates on a risk-adjusted basis, and then look at their data and try to understand, are they doing something different than all the other hospitals? Based on the claims data, you know what are the diagnostics that they are doing, what are the procedures they're prescribing, what are the drugs that the patients are taking, who are the physicians that they are seeing them. Can we infer something from them about what is the standard of care that they're following, and can you replicate that standard of care? Using the same approach, you can also look at patients. This system can rank patients based on their readmissions risk. Can you find the patients who are at high risk of readmissions based on the analytics, but they ended up not getting readmitted? So these are the high risk patients that ended up being out of the hospital. what is different from those patients than the high-risk patients that got readmitted? Again, were there certain diagnostics or procedures done on these patients? Are there community physicians that work with these patients that are different from other patients? So can we learn from what is going on from the high-risk patients who never get readmitted, and can we apply these learnings to all the high-risk patients? And finally, the fourth thing that we are working on is integrating your own data with an understanding of referral patterns. So once a patient leaves the hospital, they are not necessarily under the control of physicians that are affiliated with the hospital. They go and work with community physicians. So can we understand how these community physicians work? So what you ideally want to be working with are community physicians who will be referring their patients back to you, but they are not going to get a patient readmitted within 30 days or 31 days. So even the one that will do the 31 days, that's not the physician that you want to be working with. But looking at the referral patterns of the physicians that care to the patients once they leave the hospital, and understanding which of those physicians seem to be doing a good job keeping the patient out of the hospital, that also informs you who you should be working with as part of managing this readmission penalty. Okay, so to put everything together and to conclude, so the Medicare readmissions penalty is here, and it's here to stay. Predictive modeling technology, like the one we have developed here, can help you determine where to focus. It doesn't tell you what to do, just tells you where to focus. And oftentimes, like most management problems, knowing where to focus is 50% of the solution. In addition, our own risk adjustment methodology incorporates socioeconomic factors in addition to the factors that Medicare is using. So in that respect, it's more accurate, but it doesn't tell you why certain socioeconomic factors are actually associated with higher readmissions rate. In terms of long-term solutions, one area that we both feel very passionate about is increasing patient engagement. So a lot of things that contribute to hospital readmissions have to do with, does the patient understand the discharge instructions? And are they well equipped to follow up these instructions once they leave the hospital? So paying attention on that communication and making sure that the patient can follow up on those instructions is likely going to have a positive effect on readmissions rate. But unfortunately, there is little hard evidence about which steps are the most effective. There is simply not a single magic bullet. There is a combination of things. You could hire an army of billing specialists that are going to be expensive, and that could affect your readmissions rate. Or you could have an ambulatory ICU that will focus on the high complexity patients and try to keep them out of the hospital. But what we don't know yet is what is the cost and what is the effectiveness of these different ways of trying to keep patients out of the hospital. And when we're researching this space, there are some people who just said, well, we're just going to accept that this is a reality, this is the cost of doing business, and there is nothing we can do about this. All the other things that we can do are too expensive. And also, like everything else in medicine, there is a possibility of doing harm. At the VA program, they have instituted this pilot where they tried to help chronic lung disease patients learn to take better care of themselves. And they stopped that program prematurely because 28 of the patients in the program died, while only 10 patients that did not have access to that program died. So this thing can backfire. And then finally, there is the culture and the organizational structure of academic centers. So in academic centers, there are incentives, and you get rewarded for biomedical research. Typically, you don't get rewarded for applied research, and probably you're not going to get rewarded for applied research that helps you create these new care pathways. Now, things are changing. I know that here at Stanford, Arnie Milstein has a center that he started to study this exact type of problems. But there needs to be a broader change in the culture of academic medicine to reward the type of research that would help you focus on adverse events like the ones here, hospital readmissions, and what to do about them, and have both the research funding, the recognition, and the reward associated with research that helps you identify what you can do to keep patients out of the hospital. So analytics can help you start with that, to help you figure out where to focus. But when it comes to what to do, it's the clinical expertise that you have internally that can help you identify the actions that you can take to manage these readmissions. So, thank you for your time. And if you have any more questions, we'll be more than glad to answer them.
Did CMS use an analytic approach for creating the algorithm, or did they just use an arbitrary approach?
They used, it appears that they have used an analytic approach. So they used, I think the algorithm that they used, I think is the appropriate algorithm. They mined the data in a systematic way to find the risk factors. So they were quite careful to develop something that worked with the data that they had available.
Those risk factors that you gave, like one was 3.4 times the risk and so on, were those obtained from CMS?
No, these were obtained from our own independent analysis. And then we went back to CMS to see whether they agree with what CMS identified. But we have our own engine that we actually developed at about the same time that Medicare was developing their own things. We did it for a different purpose. Once we learned about hospital readmission, we said, let's try our engine on the Medicare data. Let's see what we get. We're finding the same risk factors that they're finding. We're finding some additional risk factors because we have a different way of analyzing the data. But there is an overlap.
I just say, this is very timely. And you know, as academic medical centers, we are the highest cost providers. And that is many of the engines being brought into face to regulate healthcare cost spiraling looks at the most expensive providers. So we're squarely in the crosshairs. And Stanford and Arnie Milstein and all these initiatives were very much in mind of that. I will tell you, though, that it pervades the institution. It's managing the transfer center. It's not taking patients who are clearly going to die, right? If you look at U.S. News and World Report, it is somewhat reputational, but it's mostly based upon things like observed to expected mortalities. And that depends a great deal on factors that are within our control in terms of how you describe and code an expected versus an unexpected death. For example, the terminal cancer patient. And one big disadvantage Stanford has that we're very much looking into is that we don't have the hospice. So that, you know, when a patient, we have difficulty in moving people out to hospice, therefore they die in the acute care hospital bed. So just to show you, you know, you all look at these things like about coding COPD versus calling it emphysema or something, getting the right code that Medicare will recognize. It's been said that on the cardiac service in the Cleveland Clinic, nobody ever dies, right? And the reason is, if somebody's really in trouble, they declare them terminal and move them in their same bed and they hospice in place and take them off the census of inpatient beds. I mean, that's an extreme example of gerrymandering the system, but when everyone else is doing it, we need to do it. You know, one of the reasons that Stanford is #2 in the nation on School of Medicine, but this department is 15, which, by the way, is #1 at Stanford on U.S. News and World Reports right now, right? It's our hospital data dragging us all down, right? In terms of metrics like this. So, you know, I applaud this, and you're really aiming mostly towards patients receiving this data or towards providers and hospitals?
Right now, the web application is available to patients, so it's catered to patients, but we are working with partners who are reaching patients through other paths, such as providers as well as insurers.
And what's the business model? Is it subscription or is it advertising?
Yeah, for patients it's a subscription. It's not really a business model. The subscription is more a selection mechanism to identify the patients who really care about the information and they will act upon it, because our premise, as Stefanos mentioned, is engagement. People who just don't value anything, any of the information they get, they will never act upon it. And we want to select for the patients who will actually do something about what they are seeing. And we do have evidence that the patients who do pay to use the service are actually acting upon the information. So that's the reason. In terms of business model, that is still evolving. And we're working through other partners who are in evidence-based medicine, as well as providers and payers to figure out the business model for this.
Okay.
So if you have any suggestions, we are all ears.
So are we.